To successfully apply theory in a clinical setting, nurses must plan carefully, motivate others, and overcome obstacles that arise. In this program, a panel of experts discusses how one theory, nursing as caring, has been implemented in 3 clinical settings: a long-term care nursing facility, an emergency department, and an acute care medical surgical floor. Leading the discussion is Dr. Ann Boykin, a founder of the Nursing as Caring theory. Consider how this panel's experiences can be a model for you as you implement theory in your practice.
Let's begin by talking about how did this model come to be in the agencies that you represent? How did this begin? And maybe I should begin that because I think I started it. Back in 2000, I think it was, Joe, when I approached the chief nursing officer at JFK Medical Center about the possibility of implementing nursing as caring. And the reason I did it is because I had been on many units in acute care settings and witnessed nurses in and out of rooms and just wondered, after listening to the nurses and the struggles with practice and the environments of care being not what they wish they would be, I just had to ask myself the question, would it matter if a unit was grounded in nursing as caring? Or is this just a book with ideas in it that sits on a shelf? And so I really wanted to know, would it matter?
I was at JFK. I've been there for 10 years in various management roles, and when the chief nursing officer approached me to discuss this possibility, we were starting a new unit in the hospital, and I felt that it would just be a perfect opportunity for us to partner with you to learn your theory, nursing as caring, and put it into practice, and that's what we did. The unit is a 18-bed medical surgical telemetry unit, and it was actually new construction in the facility. The hospital had expanded in size. So with the opening of this new unit, it was a perfect opportunity to help to attract new nurses to the facility, and we could start by the interview process. I was really the first employee on the unit. I know I used to joke with you about that, being the very first person, and sometimes the thought was overwhelming how we were going to make this work. But we started designing it, and I worked with yourself and other colleagues at the college to start to learn about it, and that's what we did initially. And we had a lot of work with administration to learn about it also. The chief nursing officer needed to learn, our CEO needed to learn about what this would bring, the value that this could bring to the patients and the facility. So that's how we started.
And what about you, John?
Well, interestingly enough, the CNO from JFK, her position transitioned to Boca when she became the chief operating officer. And shortly after her arrival, she broached the subject about the possibility of exploring the implementation of nursing as caring as well. When we initially began to speak, and with you and with the CNO and the vice president of nursing, at that point we were talking about possibly incorporating it onto an oncology unit, and then they talked about the emergency department. I was excited about that. At that point, I'd only been there about 9 months, and when I had arrived, my staff were approximately 80% contract, and only about 20% were my own. So one of the things we were already doing, we were in the middle of a cultural transition, if you will, within the department, rebuilding, reshaping. What did we want to look like? And so this was a perfect opportunity to do it. But I will tell you, interesting when they talk about implementing a theory in a very organized yet chaotic environment such as an emergency department. When we first heard about it, it was sort of like something out in the Twilight Zone, if you will. It was like, how do we take it from out there and bring it down into a very fast-paced environment and actually make it work? And one of the things we had found with talking with the staff was they really wanted to rebuild that environment down there to make it where other nurses would want to come work, but they also wanted to improve our patient satisfaction. And we thought this was an opportunity to begin to explore that and see if that could help us with it.
I remember that discussion when we made the decision to choose the emergency department over the oncology unit, and I almost died. Because I can remember how hard it was to even have the time to talk with nurses on a regular unit, and I wondered, how in the world will this work in an emergency department? And So it took a lot of courage to go there, but we did, didn't we?
Yes.
And Terry, what about you with the long-term care?
I was familiar with the theory since I've worked with it for many years in the college, and I've also worked for many years in nursing homes. So it's very relevant to the nursing home because it's about relationships that nurture personhood. And people who come to nursing homes need nursing care and long-term relationships. So I'd been witnessing for many years the caring in that setting and had been very humbled by it. And I think that I really wanted to be able to help the staff in a nursing home create environments where their caring was valued and where other people would realize that the caring that goes on there is very, very precious. Ann and I went and talked with them about would this be something on a unit that they would like to try, and they were very, very receptive.
In talking about it, of course, everybody wants to implement caring. You know, who wouldn't want to develop that? And it's in all of the philosophies of almost every healthcare agency, I would expect. And yet, it's such an elusive concept. So how did the implementation of nursing as caring, how did that begin? How do you get individuals in care settings to really understand the nature of caring? What was the process for helping people to really understand the assumptions and so forth about nursing as caring?
What we did was, it was real important to me as the person on the front line of this project to make the staff come to know that this was not something coming down from the ivory tower, a set of behaviors. This is how you're supposed to act. This is what you need to do. I don't want to stereotype emergency department personnel, but if you think about it, they're really focused on urgency of care. They save lives, and they're very proud of what they do, yet you have to have a tough skin to work in an emergency department setting because they're just the nature of the care, and I knew that I could not impose something from the outside on this staff. So what I tried to do and what the project was grounded in was gathering information about what mattered to those people in that setting, the patients, the family members of patients, as well as the staff members, what they thought was important. So our set of questions at the very beginning of the project included sharing a story of caring. Tell me your story. What's important in this setting? How do you see care? What is caring to you? And when we asked these questions, I gathered over about 100 interviews, and we found the things that kept recurring as common themes.
I could almost piggyback a little bit on what Sue said. In the nursing home setting, we also talked to about 100 staff, residents, and families. So we had a little different perspective. We included the residents and the families because that's the nature of the setting. And we struggled with language barriers because we have a multicultural staff. We struggled with how to help them articulate what it is they did and what they do. And when we listened to the stories, the themes that came out and the things that they said were so magnificent, whether they spoke Creole and needed a translator, or whether it was a very frail person who maybe didn't understand caring but could certainly tell the story that that girl there, she brings me an orange, she peels it every day, that's how I know she cares. When we took those themes back to the staff, which I think you did as well, they were absolutely leveled by hearing that their work was important. They were so proud. I don't think that anyone had really ever listened and celebrated what they were about and what they were there for, and it became a source of pride. It gave them voice, and that was, I think, one of the most marvelous transformations we saw.
And I can really relate to that because it wasn't in the beginning at JFK, it was more of they didn't realize that they even had a story to get. The staff didn't even realize that.
Right.
They were task oriented. Get the orange, get the ice cream, get the food, get the bedpan, get the linens, that type of thing. So when we sat down and we asked the same type of thing, we did the data gathering phase, we asked the same type of questions. And then when we did bring them back to the staff, we were able to identify and articulate to them how that was living as caring. And it wasn't until that happened that we were able to move on. And that was a very long time. That took quite a while, at least 6 to 8 months that phase took. And even, I will say, I don't know if you had this experience at your facilities, but there were people that I worked with that I felt would really be very involved in this, and they were hands off. We're not interested in this. They viewed the facilitator, they viewed myself as, oh, they're the people that are out getting all this information, but I'm the one doing all the work. And we had a difficult time with that, but what I decided to do was, I would say, I'm just going to give this person time. And I am going to let this person hopefully come into our space, as I would call it. That was very, very difficult for me as the manager because I knew I had certain goals to meet. I knew I had certain facility goals to meet. But in order to, and I had a very difficult time in sometimes articulating that to administration, but how we overcame that was we involved the CEO. And our CEO would come to the unit, and I remember, you can probably remember this meeting, and we invited him, and we used this language with him, come into our dance, and that was it. I had carte blanche after that.
Yeah, no, you, and I think John and Sue, you too, and I'm not sure Terry, used a video as a way of helping people come to understand caring. Can you talk a little bit about how it was used and the value of that?
I know in the emergency department, as we pursued implementation, one of the things we did was we took what Sue and the staff had done, not only among themselves, but also sometimes with patients and families, those stories, and we looked at Meyerhoff. Meyerhoff is a philosopher who talks about what he calls ingredients of caring, if you will. And sometimes it's hard to get staff to always conceptualize what we're talking about. So we thought if we could take those ingredients and match them with the stories, that we might get some ahas and there'd be some recognition and understanding. So that's exactly what Sue engineered with support from FAU as well as the staff. We put stories with each one of those. And after the video was made, and we played that back for the staff, and we did that at several staff meetings so that we made sure everybody got an opportunity to see it. It was almost like you could see the lights go on. It's like, oh yeah, that's what knowing is about. You know, that's what caring is about. And I think particularly for my staff, who are so in the moment, as Sue alluded to, we do everything instantaneously. Their concern was, can I really be caring? Do I have time to do that? They began to see each other do it, and it was like, oh yeah, I do that, or I could do that.
I think that nurses oftentimes do things that they consider very, very ordinary. It's just part of who they are. And when you do things like listen and show and bring to their attention and value, then those ordinary things become very extraordinary. And they then understand what this caring is, and that it isn't just something you do when you have time. So we try, even with our nursing students, to say to them, the first interaction with a patient is, can you tell me what matters most to you today so that I may care for you? So we respond to that which matters most, not our agenda of what we think should matter most. And your story was beautiful of that. That new lens that you put on, if you practice within this sort of a framework. Your first response with this lens is, what matters most to them? How do I come to know them as a caring person, and how are they living their caring?
It's putting on, like Terry said, putting on that new lens. And what one of my favorite quotes is by Marcel Proust. He says, the journey of discovery is not about seeking new landscapes, it's about having new eyes. And that's what they're looking at things differently.
Joe, I remember, I think it was your situation where you walked into a patient's room and modeled how this might live in practice that really changed everything on that unit. Do you remember that story?
Piano story?
Yeah, do you remember? Can you share that
We
story?
talk about the piano story all over Palm Beach County now.
Yes, I think everyone knows.
Everyone knows in nursing. The piano story. We had a patient who we were med-surg tele unit, like I said earlier, 18 beds. So we would get the patients from the ICU when they were a little more stable, and this particular lady came to us from the ICU. She was a 60-year-old patient who had had a massive stroke. Her left side was completely flaccid, and she was a relatively young person. I mean, let's face it, 60 years old is very young. So we had the patient, and a couple days into her care, the staff started to notice that she initially was very hopeful, and she was very energetic as as well as she could be, you know, considering her circumstances. And they noticed her starting to withdraw a little bit. They noticed her that she wasn't as talkative, that she just didn't seem as engaged, and she almost looked like she was in pain. Physical therapy was working with her intensely. And so the nurses started to ask, you know, what is it that we can do as a team to help this woman? What is it that is really most important to her? And we learned at that time that she lived in an ACLF with her husband, who had Alzheimer's, and that she was a concert pianist, and that she would play the piano for the residents every day in the cafeteria and in different settings. So when we found that out, I looked at one of my other colleagues on the unit, and I said, I know where there's a piano. I said, let's go get it. And so we did. We went down to the first floor, and we had a little piano. And I didn't ask permission for anything, and the CEO had already been invited to our dance, and he said, you all can do whatever you need to do, just let me know what you need to make it happen. So he walked out of his office, and here I am pushing this piano down the front hallway of our very busy 420-bed medical center with families and doctors and patients all over the place. And he just looked and he said, I'm not even going to ask. I said, we'll tell you later. We got on the elevator, we wheeled the piano up to the room. She was sitting in the chair at that time. Physical therapy had gotten her out of bed, and she just lightened up. Wow. So all the staff, of course, there were tears flowing, and we rolled the piano over to her side, and with her right hand, she started playing Heart and Soul on the piano. And at that time, her family, timing is everything. Her family walked into the room, and that was the end of the story. I mean, the rest is history, and she continued to progress, and we still talk about it this day. That was
inspired hope.
3.5 years ago. It was a beautiful experience.
It's interesting, as we were talking about finding out what's important to the patient. When you come to the emergency department, what's the first question the triage nurse says? What brought you here today? But you know, that may not be the same answer to that question, may not be the same as what's most important to you.
Absolutely.
You know, we've talked about the gentleman who comes to the ER with chest pain. Well, why is he here? He'll tell you he came because his wife made him come. You know, he doesn't really feel like he needs to be here, but that's what brought him. But all of a sudden he'll start fidgeting and he wants to sign out AMA, and we're trying to talk him into staying because it could mean his life. And when you ask the question, however you phrase it, what's most important to you? You find out, I've got this major project going on at work, or for the one gentleman we had, he was babysitting his children while his wife was out of town, and here he is at the hospital. And so what was most important to him was not himself. It was not the fact that he had an evolving MI. It was the fact that his children were going to be coming home off the bus, and there was nobody to greet them and take care of them. Well, when we asked that question, it was like, oh, now we know what is most important. We were able to make some phone calls to address that need. We got him to calm down. We could proceed with his care. And, you know, we had a good outcome. But unless you ask that question, you don't get to what's really most important.
Right.
And I know we've all cared for in our careers the difficult patient or the difficult family. And as we're talking about stories, we had a patient on the unit, and the husband was an elderly gentleman at the nursing desk. We might as well had just gotten him a seat and a computer and just put him there, because it probably would have been easier for him walking up and down the hallway. He was just part of the staff. And so the staff initially were a little bit like we would expect them to be, like, this, I don't have time for this, you know, this is getting a little out of control, I don't have time for this. So one of the nurses says, come with me, let me go to your room and let me talk to you and your wife and let me see what I can do. What is it that you need? And so she said ice cream, and no one had asked. And no one had asked. She just wanted ice cream. And so as the nurse is sitting there and she's doing her nursing assessment, as she's sitting there talking to this elderly, you know, husband and wife, she finds out they've been married for 55 years. And she notices the numbers tattooed on their arms. They were survivors of the Holocaust. And so, yeah, this story always is very moving. Excuse me. So the nurse says, I can get you ice cream for your wife. And he says, no, you can't. He says, you can. He says, ice cream, they don't have ice cream on the floor. And she says, I'll make you a bet. And he says, I'll make you a bet you won't get ice cream. And she did. She went to the kitchen and she got ice cream. But she didn't necessarily, the patient was a renal patient. The patient was a diabetic. And she needed to investigate and do her nursing assessment as to the value of giving this patient ice cream, because it was the patient's request. And as we got the medical staff involved in that, we realized that we needed to do a lot of work in our facility on diets and how constrictive they are for some of our patients. And is that necessarily always the right thing? And we found out, no, it's not. And so that had prompted, at that time during our project, an entire haul of our dietary department and how the menus, and that's when we instituted room service. And we instituted room service at the hospital to allow the patients to pick up the menu and the phone at any time and get whatever they wanted.
It's a great example of how a patient helped all of you grow in your competency
in all
for
disciplines,
caring,
absolutely.
because you listened and
So
changed.
Far-reaching effects of
Absolutely.
that little act.
Right.
Little act, and I put that in quotes.
And once the family, to get back to the difficult patient, once the family realized the staff no longer saw this patient as a difficult patient, because the difficulties that this husband and wife experienced fleeing Germany during this period in history was overwhelming to the ice cream request. So we were able to refocus and put it into perspective.
You know, John, going back to a comment you made before when you said caring doesn't take any more time and it's just intentional, I think that's such an important idea, because when I was talking before about how it took a long time to see a change in practice on the unit, and what happened, I think, to make the difference in practice was all of a sudden we talked about, after Joe's interaction with the person with the piano, we talked about, look, time isn't going to change. You may always only have 2 minutes, 3 minutes. We can't give you more time. So what we really need to do is figure out how to be with a person in the amount of time that we have. But time has also been identified as a barrier in practice. You know, I can't practice or do anything more because I don't have time. What do you see as barriers, or have you heard as barriers, or experienced as barriers to the living of nursing as caring?
One of the barriers that I kind of mentioned before was when I came in as the outsider, they did make fun of me. And, you know, and I could hear the comments when they didn't think I was listening, and I had to trying to understand where they were coming from, because it seemed so ordinary and so simple of a concept, yet I stuck with it. I had patience and kept moving forward with it and tried to not personalize it. And that was a barrier, was trying to get them to understand it as a substantive concept. And the movie and different things helped with that. But I think the thing that helped me the most was becoming like a staff member and role modeling. And for me to come in and just watch as an outsider or collect data would have not worked in that environment. I had to really pitch in, and even though I wasn't an ER nurse, in my basic nursing skills, I could go in and take vital signs, help people go, you know, to the bathroom. Just little things that I could do that would free up the nurses and just be an extra set of hands. Yet the CEO of the hospital, when he first interviewed me, said, when I asked him, what do you think I could do to help this model? He said, be a role model. And so that role modeling and dialoguing did help overcome the barrier of, what is this? What's this outsider bringing to us that we don't already do? You know, so I think that helped me. Meyerhoff says, it's not that my caring is better than your caring. Caring is unique for each person, and you're not, I don't want you to act like me or act like the book tells you to. Just do it as your own expression of caring, yet recognize the other as a caring person and recognize caring in myself.
But isn't that also a barrier? I mean, it's so easy for us to know caring from our perspective. The barrier is, Terry, you talked about it, trying to understand caring from other cultures, from other person's ways of being, and to honor that, that's a barrier. You know, we face that barrier, and the tendency when we don't know it is to judge or to label.
Exactly. We actually are moving ahead a little bit with a project, we're almost done with it, on cultural diversity in the nursing home. Only we're not calling it that. We're calling it more alike than different, caring across cultures. And it's exactly what you said. Yes, we are all different, but caring seems to be, from what people have told us, the grounding that keeps us the same. So rather than approach issues of cultural differences in terms of that, we approach it in terms of how are we all grounded in caring and how do we each express and live our caring. Gives it a whole different lens again. It's not about prejudice and it's not about institutional racism, which some people call it. It's about how do we live our caring and how do we support each other. So I think it makes a significant change.
You know, another barrier that I just thought about is once the nurses got the stories, and they wanted really to communicate the story with other nurses so that we really knew what mattered to persons, there was no place to record the story in practice. The practice system is all about checking lists. You know, where do we put the story of nursing? The most important thing that we have to communicate, where is it? And one of the things that happened on the unit was that, and this is huge because it was a whole system that had to approve of a decision to make an area on the computer where we could write the story. So now when they printed that off, they were actually carrying down the hall rather than the checklist. They had the story. But that
so from caregiver to caregiver, if that nurse that received the story wasn't able to pass that on, and we actually learned that very early in our research in the project, was where do we put this story, because it's getting lost in report. They're forgetting about it because the potassium was low and they had to do this, and they were going into that task mode. And so sitting back looking at that, and that's when we went to the information service department and we said, we need a place on the Cardex where we can record the story and it will then pass on naturally to the next caregiver.
A theory can inspire and guide changes in how nursing is practiced. But it takes the dedication and creativity of many individuals to implement a theory. As we'll hear from our panel, these efforts can greatly benefit patients and nurses.
Are you seeing any difference in terms of retention of staff or patient satisfaction, anything like that? Have you noticed anything?
Interesting. When I came 3 years ago, as I alluded to earlier, we had 80% contract staff. And you would mention anywhere in the organization, the emergency department, and it was like, make the sign of the cross, hang garlic around your neck. Nobody wanted to come to the emergency room. And just prior to starting through the Nursing is Caring project for us, we had said as a group, okay, we've got to turn things around. How can we do that? Because we're continuing to lose staff. We don't know who's coming in day to day. Nobody feels good about being here. And the staff agreed that we needed to change, quote, our culture. And that was about the same time we looked at Nursing is Caring and how that could help us. At this point in time, we have only a couple of nursing vacancies, and the ones we do have, we have candidates in-house that are applying to come to that. Our employee satisfaction this last year was the highest in the entire organization.
The complaint letters have dropped from like 13 to 2 or 1. I mean, like 75% or some big number that they really saw a drastic decrease in the number of people who have some problem.
And just yesterday, our guest relations director stopped me in the hall. She said, I can't believe how many compliment letters we're getting from you all over the last several months. She goes, there's something different. So the complaints are dropping, but the compliments are increasing.
The quality of those letters are incredible. Too.
We did some post measures, and I think all of you did or will in your projects. And we did a resident and family satisfaction instrument that's designed for the nursing home, and those scores significantly increased following the project. But what was even more exciting is our turnover on the unit. We had the lowest turnover in the facility, and if you know anything about long-term care, like I was telling you at our break, turnover is anywhere from 90 to 99%. So those are outcomes that they're not only rewarding, they're quantifiable.
They're startling.
They're a way to demonstrate the impact and effect of these kinds of things that we've been talking about.
Well, it has a financial impact on the organization directly, not only with patient revenues, but with expenses. You know, when you have to constantly replace staff and reorient and bring that in.
We had similar outcomes, as all of you have mentioned. We use one of the national databases to track our patient satisfaction, and the questions directly related to the care given by the nurses went from the 10th percentile to the 90th percentile, and in some of the areas actually went to the 99th percentile through hospitals throughout the nation that have the same type of bed size that we do. So we were comparing ourselves to similar size and larger institutions. So that was remarkable.
I was just tag on one little thing. On the staff in the nursing home did a coming to know book about each resident. So when the resident was admitted to the nursing home, many of them can't tell you because they may have dementia. At the first page of the book, they designed, and it said, "We are the staff of the B wing, the wing that has these caring values," and they listed the themes. We come from different cultures, we speak different languages, but caring is our universal language. Listed the names of the staff. Then there were pictures. What do I like to wear? What do I like to eat? What did I do for a living? And so that was completed when people were admitted. A Know Me brochure, I guess, or a Know Me booklet. So it's very interesting because when we were at the Caring Conference in Montreal, I don't know if you saw the poster from one of the hospitals, and they had a thing they put outside the patient's room, which was a Know Me, and it had some of that, the family could write on it and do things. So we have a lot more work to do. I mean, those things are really very valuable.
But as a nursing leader, I have to say, you know, it's an honor being able to use this in a practice setting. It is incredible to be able to give back to the patients, and it is also very, it is, like you said earlier, Terry, humbling to be able to realize that the essence of nursing truly is caring. And in order for myself as one of the directors of nursing to instill that in others, it's important that I never lose sight of that in everything that I do in the policy and procedure development, in the teams that I sit on, and as we all do sit on those types of teams in our organizations. It's important that my role to all the nurses behind me and with me, in front of me and around me in the dance, that everything that I do every day embodies, and we never forget the patient. And that is, and sometimes, as we all know, that's difficult with the administrations, the political nature of our organizations, and the dwindling healthcare situation in our country. So it is always a challenge, but it's a pleasure to be able to have the university to continue to grow.
It is. It's a privilege to be part of this project, I feel.
And I think one of the best byproducts out of all this that I'm recognizing is, as we go through implementing nursing as caring, it affects us as individuals. I find that even in my own personal life, I'm asking myself, what's the caring thing to do? And as people transition from one role within an organization or even to another organization, such as the CNO you have, who's now our COO,
yes,
they take those elements with them so that we are creating people who are for a lifetime caring individuals. It's not just a role, it becomes who we are. It's a byproduct of our involvement with that and our acceptance and embracing that.
So it's transforming.
It's transforming
That's exactly
practice
Transforming practice.
through